So for decades, our entire definition of type 2 diabetes has really boiled down to one number, blood glucose. But we all know in the clinic that this simple diagnosis often masks a much more complex reality. Today, we're going to explore a new framework that's redefining how we understand adult-onset diabetes, and it's moving us toward a future of truly personalized care.
And that brings us to the central question driving this whole reevaluation. Are we really just treating one disease, or are we treating many different conditions that all happen to cause high blood sugar? The clinical reality we see every day really points to it being a much more diverse, heterogeneous condition.
This is the core of the problem. A diagnosis based solely on hyperglycemia just obscures all the different underlying causes, the different etiologies that get a patient there. Think about it. Two patients can walk in with the exact same HbA1c, but have arrived there through completely different pathophysiological routes, and that has huge implications for their prognosis and, of course, their treatment.
So, here's our game plan. First, we'll quickly touch on the limitations of our current view. Then, we'll dive into the breakthrough classification system and the 5 distinct subtypes it identifies. Most importantly, we're going to connect these subtypes to specific complication risks, and then wrap up by talking about what this all means for personalized treatment right in the clinic.
All right, so let's start by digging into why this new approach is so desperately needed. This one-size-fits-all, monolithic view of type 2 diabetes, it's just not working, especially for our most vulnerable patients.
The truth is, type 2 diabetes isn't just one thing. It's a syndrome, right? It's this complex interplay of genetics and environment. And what that leads to is this incredibly wide range of clinical presentations. You see everything from lean individuals with profound insulin deficiency to obese patients with extreme insulin resistance. And, no surprise, their disease progression and their risk for specific complications are just as varied.
This whole challenge of heterogeneity is exactly what led to a really groundbreaking study out of Sweden that offers a powerful new solution. So let's take a look at how this research builds a completely new framework for classification.
So, the Ahlqvist study, what they did was take a completely data-driven, unbiased approach. They analyzed this massive cohort of newly diagnosed patients, and instead of starting with preconceived notions, they let the data itself reveal the natural groupings within the population.
And they did this using 6 pretty simple clinically available parameters. First, GAD autoantibodies to screen for autoimmunity. Then, age of diagnosis, baseline HbA1c, and BMI. And then, and this is absolutely critical, estimates of beta cell function and insulin resistance using the HOMA models.
The real power of this whole classification system comes from using these HOMA models. These calculations, which you get from fasting glucose and a C-peptide level, are what allow us to really differentiate the underlying pathophysiology. And this just highlights the absolute necessity of measuring C-peptide at diagnosis if we want to distinguish between primary insulin deficiency and primary insulin resistance. Okay, so using these 6 parameters, the Ahlqvist cohort just naturally clustered into 5 distinct and reproducible subtypes. This is where we really start to deconstruct that single diagnosis of type 2 diabetes.
And here they are. You've got 2 milder forms, mild age-related diabetes, or MARD, that's the biggest group, and mild obesity-related diabetes, or MOD. Then you have the 3 severe forms, severe insulin deficient, severe insulin resistant, and severe autoimmune diabetes.
Let's really zero in on these 3 severe subtypes because this is where the highest risk is. SID is your GATA-positive group. Think LATA, think classic type 1. But the other 2 are GATA-negative. SID patients are characterized by a profound insulin deficiency, despite being antibody negative, and they usually have a low BMI. Now, in stark contrast, you have SIRD patients. They're defined by severe insulin resistance, high HOMA-IR values, high BMI. Their primary defects are polar opposites.
Now, the 2 milder subtypes, they're just less metabolically extreme. MOD is mostly characterized by obesity, but without that severe insulin resistance you see in the SARD group. And then MARD is the most common group of all, characterized mainly by older age and onset, but with no other really extreme features.
All right, now for what I think is the most critical part. How does the subtyping actually predict patient outcomes? This is where this framework moves from being just an academic exercise to a vital clinical tool.
So, here is the crucial point, this incredible decoupling of microvascular complications. We've all been taught that retinopathy, neuropathy, and nephropathy kind of travel together. Well, this data shows that's just not true. Retinopathy and neuropathy are overwhelmingly problems for the insulin-deficient group, SIOD. Kidney disease, however, that's the domain of the insulin-resistant group, SROD. And this just brilliantly illustrates how aggressive that SIDS subtype really is. A staggering 23% of these patients already show signs of at least mild retinopathy when they're screened shortly after their initial diagnosis. That tells you that significant microvascular damage has already happened by the time we even meet them. It points to a really rapidly destructive disease process.
So, the high-risk profile for SIDS is crystal clear. They have confirmed low C-peptide, they have the highest rates of sensory-motor polyneuropathy, and the highest rates of cardiac autonomic neuropathy. The clinical takeaway here is unambiguous. These patients need early, intensive treatment to replace their deficient insulin, and they require very, very frequent complication screening.
Now let's flip over to the SIRD group. Compared to the mildest MARD subtype, patients with severe insulin-resistant diabetes have a nearly 5-fold increased risk of developing end-stage renal disease. That is a massive elevation in risk, and it's driven by insulin resistance, not just hyperglycemia.
And the risk for SIRD patients doesn't stop at the kidneys. Nope, they also have the highest prevalence of NAFLD. Studies show their average liver fat content is around 19% compared to less than 7% for the other clusters. This isn't just some incidental finding. It's a key feature of the profound metabolic dysfunction in this group. This truly is a multi-system disease of insulin resistance.
So, with this new understanding of the pathophysiology and the risk, how do we translate it into better patient care? Because that's the ultimate goal, right?
Well, this framework finally allows us to match the treatment to the underlying defect. For a SIDS patient, the goal was to address their insulin deficiency, which suggests early and intensive insulin, or maybe GLP-1 receptor agonists. But for a SIRD patient, the focus completely shifts to improving insulin sensitivity, with agents like thiazolidinediones and aggressively protecting their kidney function, maybe even before significant hyperglycemia develops. But as we think about implementing this, there are some key considerations. First, C-peptide measurement is non-negotiable. You simply cannot accurately identify the high-risk SIRD group without the HOMA calculations. The simplified models just fail here. Second, this absolutely needs more validation in diverse ethnic populations. And finally, these clusters are not necessarily static. One study showed about a quarter of patients changed their subtype over 5 years, which highlights that this is a dynamic process. Ultimately, this is the big takeaway. Subclassification gives us a roadmap. It allows us to move beyond a one-size-fits-all approach and finally start practicing a more precise, stratified form of medicine, targeting the right treatment and the right screening to the right patient at the right time.
So, I'll leave you with this question to think about in your own practice. If you knew from day one whether your next patient's primary defect was severe insulin resistance versus severe insulin deficiency, how would that fundamentally change your initial conversations, your